Welcome, everyone. I'm so glad that you're able to join us today. This is a series of webinars sponsored by HRSA and the National Center for the Integrated Behavioral Health. We're working on different ways of improving integrated behavioral health and of using health equity as a guiding North Star in the work that we're doing. During this webinar, if you have questions, would ask you to look at the Q&A box at the bottom of your screen. If you would type them in there, I will monitor the questions, and when the presentation is over, I will come back in and ask questions to our presenters. Let's get started. We have three presenters today. They are Dr. Matthew Martin from Arizona State University, who has done work in the competencies that seem to be required for successful work by medical clinicians in integrated care, with particular attention to successfully implementing integrated care. Our second clinician is Dr. Larry Mauch. Dr. Mauch has been a pioneer in the evidence-based delineation of patient-centered behavior by medical clinicians, and Dr. Richard Pinckney, who, along with Dr. Martin, has been active as a medical clinician in defining medical clinician role in integrated care. And with that, I will pass it to Dr. Martin. Matt, go ahead.
Thank you. Okay, I'm going to share my slide deck. You can see this. Okay, so this is the title of our presentation: Preparing Medical Clinicians to Practice Integrated Behavioral Health, Ideas for Accelerating Workforce Development. And we're thankful for the opportunity that we have to present and share our ideas and get a discussion going. This is what we're hoping to cover today. I will read our bios in just a second. We're also going to talk about the rationale for this work, common challenges in education and training, current efforts to standardize and accelerate, and then we'll have an opportunity to have a conversation and then field some questions. So as far as bios, Matt Martin is Clinical Assistant Professor of Behavioral Health at Arizona State University, where he teaches courses on healthcare quality improvement, substance use prevention and treatment, behavioral health integration, and healthcare systems. Research interests include integrated care measurement, medical workforce development, and population health strategies in primary care. Prior to ASU, he served as Director of Behavioral Medicine at the Duke Family Medicine Residency Program in Fayetteville, North Carolina. Matt has 10 years of clinical experience, including several years of practicing and managing integrated behavioral health services. Okay, Rich Pinckney. Rich is Associate Professor of Medicine at the Larner College of Medicine at the University of Vermont. He serves as the Director of the Internal Medicine Resident Clinic and is a member of the Motivational Interviewing Network of Trainers. His scholarly focus is on the intersection between primary care and psychology. He has expertise in motivational interviewing, ADHD, chronic pain, SBIRT, mindfulness, and compassion, and how to teach these skills to medical clinicians. Rich recently worked on the PCOF-funded 5-year pragmatic control trial integrating behavioral health and primary care. Larry Mauschk is clinical professor emeritus, Department of Family Medicine, University of Washington, and a nationally recognized speaker, consultant, and trainer for health system transformation. He spent 34 years as a family-oriented behavioral health clinician in primary care, training medical, nursing, and behavioral health professionals, interviewing skills, team development, and management of behavioral disorders. He is a former editor of Family Systems and Health Journal, former board member of the Society of Teachers of Family Medicine, and founding board member and past chair of the Collaborative Family Healthcare Association. Mr. Mauschk's training uses role models, peer coaching, video, and team exercises. His research examines educational strategies to maximize the effectiveness of team and clinician communication on patient satisfaction, health outcomes, and clinical efficiency. Additional areas of educational and research interest include competency assessment and the integration of behavioral health and medical settings. So I'm going to continue by talking about the rationale for training medical clinicians in IBHPC, which is integrated behavioral health in primary care. And I'm going to be talking about it from three perspectives: clinical, financial, and operational. So I'll start with clinical first. So integrated care training is important because of how common behavioral health needs are in healthcare. Here you can see behavioral health used as an umbrella term, encompassing other topics like mental health, substance use, health behaviors, stress, and relationships. We could also add any patient behavior that's required for treatment adherence or acceptance of medical intervention, like a vaccine. The benefit of taking on this broad definition of behavioral health is that it facilitates a holistic biopsychosocial perspective of the patient. Medical clinicians using this perspective begin to see how there is no medical condition without some behavioral component, and also how there is no behavioral health condition without medical implications. So this perspective is crucial for integrated care to work, but it's not a regular and foundational part of medical training. Here you can see behavioral health within a chronic disease framework. The left panel shows the influence of health behaviors like alcohol or tobacco use on the development of chronic diseases. Then between the second and third panels, you can see a bi-directional relationship between the chronic disease and the ongoing behavioral health issues. So for example, a patient with diabetes faces risk for experiencing depression episodes, a mental health condition that can easily complicate the diabetes management. So integrated care training introduces or reinforces these clinical ideas that I'm presenting here. I once worked with a wonderful and capable internist at a rural medical clinic. And at first, he only referred to me patients with suicidal ideation. Over time, and after many discussions, he began to refer patients with mental health, substance, and health behavior issues. Okay, let me talk about the financial rationale. So here you can see two examples of how behavioral health issues increase medical costs. With comorbid anxiety, there is a 67% increase in monthly healthcare expenditures for those with chronic conditions and comorbid anxiety. So expenditures for patients without anxiety are $870 a month compared to $1460 a month with anxiety. And then you can see a similar comparison for comorbid depression, a 54% increase in expenditures with a comparison of $840 a month versus $1290 a month. However, this report does not indicate if the patients with comorbid mental health conditions received behavioral health treatment. So we don't know if that's part of the calculation here. But here, this does show that behavioral health is a part of increasing costs. Here, this is showing results of a study that I did a few years ago. This was an evaluation of a healthcare insurance company who had trained all of their case managers in a highly structured integrated care program. So before the training, a member of the with benefits, if they had a medical question, they had to talk to a nurse case manager, and a member with a behavioral health question had to talk with a social work case manager. After the training and the implementation of the integrated care program, the case managers could handle any request coming in. Our evaluation showed that members who had participated in the program had a higher percentage of medical appointments post discharge from the hospital. They also had fewer days between their medical appointment and the discharge. There was a sharp decrease in costs, and the members were highly satisfied with this integrated care manager program. So the results taught us that integrated care training works within different parts of the healthcare system, but that it does require open communication between the case managers and leadership, and a culture focused on practice improvement. So that's one thing to keep in mind as we talk about training, is that training alone is often not enough. Finally, I will mention operational rationale for integrated care training. There's a temptation to hire a behavioral health clinician, like a psychologist or a social worker or a family therapist, and then stick them into the medical clinic and label the team as integrated. However, from an operational standpoint, that does not work very well. It can create frustration for all the team members. Dr. Pinkney will share an example from his own organization about the consequences of that approach. Here, I want to share with you a conceptual framework that members of my team here at Arizona State University have developed. This framework helps to better understand integrated care team development from a systems viewpoint. So starting at the top, you can see inputs like shared mental models, shared leadership that contribute to the initial formation of the team. These are the starter ingredients, so to speak. The patient and family, as you can see in the circle, are core team members. As the team begins to interact and work together, cohesion and adaptability are essential factors for the team performance. At the bottom, you can see the outputs of a functioning team that can include behaviors like closed loop communication, patient identification, and shared treatment plans. So I'm going to stop now and turn it over to Larry Mausch. He's going to talk about common challenges in training, but also maybe drill down a little bit more on some of the specific behaviors that you would see on an integrated care team.
Thank you. Thank you, Matt. That was great. It's a good lead in. Go ahead and go to the next slide, Matt. So my premise for what I'm about to say is that there are two barriers and two areas, therefore, of intervention that I'd like to highlight in helping medical providers actively and successfully participate in integrated teams. And one of those is to recognize that they are part of a team and to be surrounded by a fully equipped team that has a breadth of behavioral health expertise in both roles, examples of roles across the top of the slide, and functions, a variety of different things that members of the team, all members of the team, have to be able to contribute to. So when we think about a transdisciplinary team, we're making a distinction between that and multidisciplinary, interdisciplinary. Multidisciplinary is where a bunch of people work together and they don't think about the needs of other members of the team or the patient's needs, they just document their work. Interdisciplinary people document their work in the interest of supporting the work of others, but they don't think about how they can fill the gaps that naturally and inevitably exist between the work of members of the team. So they're thinking about the needs of the patient, not just the confines of their discipline. So everybody on the team, for example, is responsible for fulfilling core functions. The most important of which at the top is relationship. And as you work your way down, you can see examples of other functions that exist on a team. And I'm going to come back to this in a minute. You'll see it in a better schematic that make a difference in providing quality of care. Depending on the complexity of the patient, various members of the team have different levels of intensity involvement. And in combination, all of these members come together to provide a play, to create plays, just like basketball teams and football teams and have plays. We come up with plays for simple patients, and we come up with plays for complicated patients to make sure that what needs to get done is done by the time they leave the clinic, and by the time and through our contacts with patients outside of their face-to-face involvement with us. Go ahead to the next slide, Matt. So there are significant barriers, and none of these will be a surprise to you. Finding time is a big deal. And there are financial barriers, of course, incenting behavioral health support. A big issue, and I worked training primary care clinicians for over 30 years. Many people come out of medical school with dualistic thinking, wanting to separate out how you deal with behavioral health issues from medical issues, and don't understand the interplay that was nicely portrayed on Matt's slide. We don't give them specific language to describe the specific skills, like we give them language to describe skills they do when they suture or do a physical exam. And training systems have competing priorities, and there's a huge need for faculty development to be able to train future doctors and be effective role models. Next slide, Matt. So you've all will have or already have access to the patient-centered observation form, the PCOF. This is an online training site that is free to use and is designed for primary care providers and their MAs and nurses to work together and to use it. A key part of the Accreditation Council for Graduate Medical Education Outcomes Project, the center part of which is competency-based medical education, is direct observation, not just for behavioral health or communication skill development, but for really just about all of the competencies, the 6 competencies that the ACGME wants all medical disciplines to monitor in the development of their trainees. So direct observation for communication skills and behavioral health skills is key. You can't know if our trainees are really using skills unless we're directly observing them. Next slide, please. So the skills that are on the PCOF that are now more broken down even further on the form itself are listed here. There are communication skills that, as you can see, are used in every single interaction, but those skills represent the core of what goes into a successful behavioral health interaction to help a patient accept that they need to change their behavior to manage their diabetes, or to understand the fears that a patient has in proceeding with care because they've been victims of abuse, or to understand how a patient from a marginalized population because of race or ethnic origin is afraid to trust their healthcare providers. These skills help medical providers get at the core issues and provide better care for their patients. Next slide, please. So in the best use of all worlds, so Matt, every time you press the button, there'll be a new part. And so when we start, we might, hold on now, we might have patients actually sign into clinics using electronic connections if they're available to identify what their core needs are. Next, Matt. And somebody at the front office will continue in that process to greet the patient, acknowledge a pre-visit agenda. Next slide, please. Next click. Then, depending on the needs of the patient, either an MA or a nurse or a behavioral health person will meet the patient, further elicit agenda and figure out what's important, activate the patient to address issues like health behavior change, kinds of problems to manage chronic conditions, and sets up the visit with the primary care provider. Next, Matt. who provides the primary care expertise and care, and then who next, Matt, who then passes the patient on to someone at the end to finish and provide follow-up. And this represents, team care. So if we can directly observe our medical clinicians, we can give them feedback in a range of skills. This is now required by the ACGME. If we can surround them in a clinic system that has integrated and embraced a full approach for addressing the range of behavioral health issues, then we can, I think, accelerate the success of behavioral health training of our medical clinicians. Accomplishing this means recognizing these are barriers and recognizing that they are keys to success. So I'll now pass this on to Dr. Pickney.
Okay, can you see me all right? Great. So yeah, we can turn the slides off for a moment. I'm going to talk a little bit about measurement. How do we measure the readiness of medical clinicians to practice integrated behavioral health? But before I do, I just want to share a little bit of a story. I've been interested in psychology and its relationship to medicine for a long time. It was actually part of the reason I wanted to become a physician, and have always been interested in things like chronic pain and migraines and mind-body medicine. And so when I heard that my clinic was getting a behavioral health specialist, I was excited, and I was actually on the selection committee, so I got to interview the applicants. And so the person was hired, and me and my other colleague who ran the internal medicine resident clinic were excited. We actually got grant funding to develop some pathways for the resident clinic. And we sat and we met on a regular basis. I love Larry's analogy of the playbook. That's exactly what we did. We would pick a condition like chronic pain, and we would map out exactly, okay, I'm going to do this. These are the tools I'm going to use. These are the measurements I'm going to make, like the COM or the SOAP-PR. And then the behavioral health specialist is going to see them, and they're going to do these measurements. And then we're going to get back together, and we did team meetings. And we did this for several conditions. We kind of mapped that out. And it was incredibly rewarding. And then it suddenly dawned on us, we're the only ones doing this. We're in a pretty large practice. We have many medical providers, probably about 8 to 10 at any given time. And there had been a lot of buy-in from leadership. There had been a lot of investment in the integration from the front desk person through nursing, but there had been zero integration when it came to the level of the physician and other medical clinicians who are working there. And so everybody else was sending depression and anxiety, just like has been mentioned before. And it turned out it wasn't enough business to keep that person busy. And there were other factors at play. That wasn't the only one, but eventually that person left and they weren't replaced. And now I'm currently without a behavioral health specialist. And that experience was both rewarding and frustrating because it just etched in my mind how important it is to train the medical clinicians in terms of truly recognizing what kind of problems that they're seeing that they could get benefit from a behavioral health specialist. And as Matt alluded to earlier, it's almost everything. Certainly strep pharyngitis doesn't require a behavioral health intervention, but congestive heart failure, migraines, irritable bowel syndrome, asthma, COPD, diabetes, like all the bread and butter things that we do, even wellness visits, really would benefit from working as a team as opposed to solo. My other experience coming into this is that I am the resident clinic director, and one of my favorite things to do is to train the incoming interns. And I train them in motivational interviewing using techniques such as SBIRT, self-management goals, and communication skills. And I either formally with a survey or informally with a show of hands just ask people, well, what do you know about things like SBIRT? What do you know about motivational interviewing and other things that would fall under the kind of the domains of integrated behavioral health? And they're all over the map. Some people are coming from medical schools that have zero experience whatsoever. They haven't even heard of these terms before. And others come in like quite skilled already. And the same is certainly true of new people we hire to be faculty members. They're coming from a wide variety of training programs. So having all of these experiences kind of coming together for me created this perfect storm in my mind of, boy, like we're flying blind here. Like we have no idea how much our medical folks know, and we sure better know, because if we don't know, we're going to land flat on our face. And we're going to be hiring a behavioral health person again soon. And so we really need to get a handle on this. So what Matt and I have been doing is developing and now validating a tool, Competence for Integration Profile, that is essentially a tool that measures like a yardstick exactly how much people really know about practicing integrated behavioral health from the medical perspective. And I'm not going to get into all the things about designing a survey and what's involved, but we relied on experts in the field, as well as things like the Milestones program for residencies, in terms of what things everybody kind of agrees are key competencies that a medical professional needs to have when it comes to integrated behavioral health. And so there's lots of applications. Slide, please. There's lots of potential applications for this. Next slide, there we go. So as I suggested, when residents come into a training program for residency, we can figure out exactly where they are and adapt our curriculum to them. We can see at the end of resident training, when they graduate, as kind of an exit interview, we could use this tool to say, did we hit the mark? By the time they left and are ready for practice, do they have the competencies that they need? We have a lot of new hires lately. Primary care is really growing in New England right now. And what do they know? Did they leave their training programs? And I'm also actually in charge of faculty development for junior faculty. And so I really need to know what they know. Needs analysis. We have a number of clinics in our group who are hiring behavioral health specialists. Are those medical providers ready? Do we need to be doing in-service training? Curricular evaluation of that mandatory staff training. And then last but not least, myself and others are interested in developing, experimental training methods, especially me, very interested in training the medical professionals. And you need to have some kind of tool, some kind of yardstick to see how effective that training method is compared to others. Is it worth the extra effort in innovation? One more slide. So if anybody on the webinar is interested, we are kind of in the last roughly month of our validation process for this, and we have room for more medical providers to complete the current version of the CIP that we have. So if anybody out there is interested, that's Matt's contact information, and we'd love to have folks from around the country participate. The more diversity, the better in terms of validating this tool. So thanks.
Thank you, Rich. There was a question about if it's appropriate for the CIPs is appropriate for medical residents. We are currently recruiting medical students, medical residents, as well as physicians, PAs, and NPs. Yeah. And they can be in training or out of training.
Yeah, it would be great for us to be able to see, oh, medical students come in and they're scoring at about this level, but on average residents are this much higher, et cetera. So it'd be very helpful.
Great. Thank you. And let me also mention that's a paid participation. So everyone who completes the survey receives a $50 gift card. Okay, so before we get to the panel discussion, I wanted to describe one more project related to integrated care training for medical clinicians. When I taught in a family medicine residency program, it was my responsibility to train the residents in integrated care. However, I had no established targets for my training. I was essentially guessing what skills and knowledge I thought they needed. So a team of residency educators got together, including Larry Mausch and myself, and we completed a study using the Delphi method to generate consensus on the essential skills that family medicine residents needed for practicing integrated behavioral health in primary care. That study was published in 2019, and you can see the citation at the bottom of this slide. So we answered the question about essential skills for residents, but that begged the question, do these skills apply to other medical clinicians who are not residents or who are not physicians? We completed that study this past year, 2021, and the manuscript is currently under review. In short, we found that the majority of the skills from the first study did apply to non-resident physicians, PAs, and NPs. Here is a list of the domains that organize the essential skills from our list. We have interpersonal communication, collaboration and teamwork, screening and assessment, care planning and care coordination, intervention, social cultural competence and adaptation, and professional values. And again, these are all essential skills for medical clinicians practicing integrated behavioral health in primary care. So here you can see an example of how these essential skills maps onto the ACGME milestone framework. This skill is from the interpersonal communication domain, and it's for a medical clinician to clearly convey relevant behavioral health information in a non-judgmental, jargon-free, and person-centered manner. From left to right, you can see the specific behavioral anchors we would expect to see depending on the developmental level of the individual. So for example, a beginner would be expected to introduce behavioral health care to a patient using easily understood language and explain the value of behavioral health consultation to the patient as well. Compare the behaviors in level 1 to the behaviors in level 5, where an individual is teaching communication skills and creating new patient materials, very similar to what Rich does on a regular basis. We created behavioral anchors for all of the essential skills, and we have a long list of these behavioral anchors. And the reason we did this is because we really wanted to map out what are those specific discrete behaviors that demonstrate that a medical clinician is practicing integrated care. So this resource, it's useful for curriculum and program development, but it's really long and it's cumbersome. So we developed something else. So I believe that, along with what Larry was saying before, that observation and feedback are a crucial strategy for training and performance monitoring. So for example, if you want to improve your motivational interviewing skills, you could record a conversation between you and a patient, and then you could send that recording to a coding lab or to a coach, a motivational interviewing coach, and then you can receive personalized feedback on your performance. I've actually done that and really benefited from improving my motivational interviewing skills. So we are looking to see if we can do something similar for medical clinicians that are learning how to practice integrated care. So we took the almost 200 behavioral anchors, and we created a much shorter observation tool that can be used in training students, residents, and professionals. And we base this off of other observational tools like Larry's PCOF, as well as the motivational interviewing coding, the MIghty. We drew some of the ideas to form this observational tool. So we're currently finishing this tool, and we hope to pilot it later this year to see if we can establish inter-rater reliability for the tool. So that's just another project where we're really trying to better understand what are these essential skills, can we measure them, what do they look like, and can we create tools that are helpful for not only for education and training, but also that are helpful for hiring, for recruiting, and for performance monitoring over time. So at this point, I'm going to stop sharing the slides, and we can move over to a panel discussion. So I'll give it over to Larry to facilitate that.
Sure. So I'm going to put out a couple of questions, and I'm aware we have to monitor the time, but let me put it out to all of you for starters, including Richard and Sandy, if you want to contribute too. You have a wealth of experience with all of this. Who do you think should be providing the training, the feedback for primary care trainees? Should it be just behavioral health providers? Should it be the primary care clinicians on the faculty, the doctors or the nurse practitioners or PAs who are on the faculty? Who should be doing that? Who should be doing the direct observation and feedback? And what are the barriers that we need to recognize and how to overcome getting those folks involved? Whoever should be doing that.
I can take a stab at it. I think that one of the best things that we can do in education is role model what it is that we're trying to teach. So I've had an opportunity on several occasions to teach on a team. So, to work with a behavioral health specialist in a team environment, to teach together and role model our professionalism and our teamwork in the educational environment. I think that's a win-win. Of course, the cost of that is expensive, right? Because you've got at least 2 faculty members that you're now using to teach something. So, but for certain workshops, especially like for an intro to integrated behavioral health, I've done that before for training, like expert training, to have multiple members of the team for that. I think for certain high profile education, having a team directly doing the teaching together is probably good. And then probably separate, but both team members involved intermittently throughout the rest of people's educational experience. That's my hunch. I haven't seen data showing that that's best.
I don't know if it's best or not. A colleague and I and some others at the Department of Family Medicine at UW, Richard, we actually did that for 6 months. We had a behavioral health provider and a physician directly observing and precepting our resident interactions. So they would be observed by a closed circuit TV, and then they'd come in and they'd precept. And we studied the experience. This was published in Family Medicine. First author is Valerie Ross. I'll send it to you and others who are interested in it. And we discovered that by directly observing and having an interdisciplinary team do that, the richness of the precepting experience was profound. No surprise.
Yeah,
no surprise.
We did that. We began that in 1999, I guess, at UMass, and I think it's still going on. The idea was that we would have the behavioral health person and the on-duty preceptor looking at one resident and their patients, with the on-duty preceptor having to step out occasionally for other residents, but mostly
Right.
you got the time. And what it meant was that not only were the faculty able to teach, have the person articulate the teaching from the voice that was most credible to the resident, it allowed you to develop the faculty, because the behavioral health person often had ways of teaching that the preceptor would learn from. We tended to take a strength approach to watching residents and catch them in the act of doing it right. And that over time was useful as a faculty development tool for the whole site.
One thing, I don't have a lot of experience with this, but one thing that was a win-win when we did do that is that, the medical preceptor, of course, oftentimes has up to 4 residents that they're trying to precept at the same time, but for billing reasons and supervision reasons, but the behavioral health expert doesn't. They don't have to be there for all 4. So what was happening is the behavioral health expert was actually going in the room and doing direct observation, while the medical preceptor was not, but they were there to report the medical information. That worked actually very well.
Yeah. We had both people behind a one-way mirror. And what that provided was this incredibly rich moment behind the one-way mirror where other behavioral health clinicians could learn. Our interns would be there learning from the conversation between the preceptors about not only what would be better for the patient and the resident that they were watching, but how to tell the resident in a way that would be most useful for them, what the strengths were that we were seeing. So that we called it team precepting, and it was and still is done in all residency sites.
One of the things that many medical faculty will say is we don't have the time to directly observe. And one at least partial solution to that I would offer is the first patient of every clinic is when you're most likely as a medical clinician to be able to observe, especially if you have closed circuit TV coming directly to your computer, where you can also be looking at the electronic medical record of that patient and still yet remain available if other residents need help. But by definition, the first patient of any clinic, no other residents are going to be coming out asking for help because they're all seeing their first patient. And so if you just watched one patient and you have 10 clinics a week, the first patient, that's 500 direct observations a year. So let me move on to another question. Let's see. Matt suggested how do we get practicing medical clinicians in any kind of continuing education or professional development to sort of embrace what we're trying to work on here? How do we sort of engage stakeholders, executive leaders, managers, payers, to align incentives to engage clinicians in integrated behavioral health training? Should integrated behavioral health training become required by the ACGME? Tough question. Thoughts?
Yeah, my thought about that question is that most of the innovation for training has happened at the medical school or the residency level. And I think that level has more space for creativity and innovation. But you also have behavioral health scientists, educators who are available for collaboration and teamwork. But it's much more challenging once you go outside the classroom, outside the residency program, to engage all of the thousands of primary care practitioners, to get them engaged in integrated care, to give them the right training, and then to give them the right support that they need to maintain their training over time. So I don't know if we figured out the right incentives and the right resources for practitioners who were never exposed to this kind of training, in undergraduate or graduate medical training. How do we align those incentives, and what are the right resources? I don't think we've figured that out yet.
Mhm. Richard or Sandy, any comments about this?
I was having flashbacks of how anxious I was when we started this, of how to get people involved, and all of the feedback of there is no time, no, we can't work this, direct observation is too intrusive on patients, all of the kinds of things that you would think. And what I found was that I got one doctor to do it. And after a while, the feedback from the residents who were being precepted was so positive because of a strength approach to what they were doing. And the enjoyment of other people got to be a little buzz in the clinic. And other doctors were saying, well, how come I don't get to do that? We said, well, actually, we can work it out so that you can. And the same thing with the other residency sites. How come their residency site gets this service and we don't? Oh, we can arrange it. So it was by not implementing it, just holding it over in a corner for about 6 or 7 months before it began to get any kind of reputation. In integration, as everyone knows, if you aren't taking the long view, you're not going to be very happy with how things go.
So I'm aware of the time. It's now almost 10 minutes before the hour. Do we want to shift at this point to some of the questions?
This is where we said that we would go to questions from the folks. It says here that I've got 4 questions.
I see some in the chat and in the Q&A. I see some in the QA and in the chat.
Okay, I'm only looking in the Q&A. But even in the Q&A, it said, oh, here we go. Here's 4. Here's the other one. Well, I'm going to read them because I didn't find them before. How are you matching the CIP items to what patients care about in their integrated care teams?
I can take a stab at that, and maybe Matt can add some more. Our experts certainly are folks who are involved in patient-centered research. So there's an indirect effect, but we did not have a patient partner, for example, involved in this research and development. We were relying more on kind of standards within residency training and milestones and some of the things that Matt talked about before.
All right, thank you.
I would add to that I think there's a lot of potential for research for better understanding the patient experience of integration. My experience or my anecdotal data says that patients don't really have a good sense of what integration is. If we asked them, they just know that people walk into the medical room, into the exam room, and they talk to that person. So I think there is more that we can do to better understand what patients think of this model and what would they want out of it.
Okay. So we have a question about the role of nurses in the work, the norming that I can't really translate it. What about the nurses, says someone. And then there's what is the role of cultural person-centered awareness in transforming stigmatizing medical language how do you have a bi-directional learning or feedback mechanism to build on your playbook?
I'll say something about nurses. Nurses are key members of the team, and in many clinics, it's the nurses who are doing a lot of the chronic illness management. So they have to be, I think, trained and willing to explore the health beliefs of their patients, to reveal occult mental disorders, to make their primary care team members and aware of what's going on, and when necessary and available, bring in behavioral health. But teams that have nurses that aren't involved in this are crippled. And nurses are a key member of the team on the inpatient and the outpatient side.
And one question, I guess this particularly goes to Matt. We're having confusion about the doctor of behavioral health degree and the term medical clinician. And so I think people are wondering if it is a degree for physicians or other medical people to add behavioral health skills for them. And is there a certification for medical clinician? So people are confused by those terms, and we have used them very loosely because we think everyone knows what we're talking about, and it turns out that's not true. So I'm dropping this on your head.
Sure. So when we say medical clinicians, and we are starting to use the word clinician instead of provider, at least Rich and I are trying to focus on that language in our CIP project. So medical clinicians, we're referring to physicians, PAs, NPs, as well as any students within those training programs as well. So these are people who can prescribe. Doctor of Behavioral Health, I'm not sure where that came from because I haven't mentioned that in the presentation. It's not a license or a certification. It's a doctoral degree. It is offered at some universities across the country. It is, I know that PAs and NPs have gotten a DBH, also behavioral health clinicians as well as healthcare managers. So it has a broad appeal to a lot of health professionals, including some medical clinicians.
It's sort of analogous, tell me if this is a fair statement, it's sort of analogous though to a sort of advanced doctoral training were it in psychology. Rich said he started being interested in psychology, and that's a focus of his medical work. And so when a PA gets a DBH, they essentially become a medical clinician with advanced training in the word psychology is now polluted because it's gone from being a discipline or from being a pursuit of people knowledge about humans to being a discipline as opposed to other disciplines. But it's psychological studies on top of a medical foundation training. Is that fair?
We have a lot of students that already have behavioral health training. We also have a lot of students that have healthcare management training, and they want to pivot and focus on behavioral health. But yeah, it's certainly an advanced degree with an emphasis on behavioral health, integrated behavioral health.
See a few more questions there, Sandy.
Thank you. Only what I'm watching is the chat scroll rather than questions.
Okay. I think that in both of those, Sandy, in both of those chats, Jennifer has indicated a sensitivity to stigmatizing language and how we describe patient experience and behavior and the impact that has. I mean, I think she's making a good point. It's very easy for us to use language because of our training that that can be harmful unintentionally, but we need to be aware. Jennifer brings up the example of the use of the term disorder. This goes back to my entire career about how do we use diagnoses and what are the meanings of them and how do patients understand them.
This is especially important now that we're sharing our notes with patients. So behavioral health specialists are now sharing the record is a very shared experience. I mean, it's very new for medical clinicians and behavioral health specialists to share a record, but now the patient's reading that all too. And we have to think.
I use the term disorder in quotes within a medical setting, because I know that for physicians who aren't yet familiar with integrated care, they need for there to be a diagnosis to feel that we're doing okay here. We're not just wandering in the woods. And once you are working together and you've been doing it for a while, the term disorder kind of disappears, just like the word psychotherapy disappears. We're doing something else here, and it's for helping this person with the needs they present today. And we're going to try and add some value today.
Let's see, we've got 3 minutes.
I'll just add a comment about one of the previous questions while you can look for more questions. As far as nursing, at least in my experience in Vermont, I think the training that nurses get is puts them in a much better position than medical doctors in terms of being prepared to practice integrated behavioral health. When we were working with a behavioral health specialist in my clinic, we'd have team meetings, and having nursing there was a really important part of the process.
Well, folks, I want to thank HRSA and the National Center for Integrated Behavioral Health, and Chaik Dobany, the director, for the opportunity to present this webinar. Most today, I want to thank Matt Martin and Larry Malch and Rich Pinkney for sharing their work that has been going for many years and is still at the cutting edge of what's happening in pushing or putting behavioral health integration into primary care forward. This webinar series will go on. We will be having new webinars in about a month on the makeup, the broadening of the primary care team, the integrated team, particularly with the addition of non-licensed professionals who are able, such as healthcare workers, who can connect both the practice and the team to the social side of the psychosocial needs of the patient, and to help integrate the practice with the community. So look for that work in a month or so. It's because you registered for this webinar, you will get an announcement. Thank you again to everyone for your time and your participation and good questions, and back and forth engagement. We really appreciate it. And thank you again to our presenters. See everybody in about a month or so. Bye-bye.